To understand gynecologic pathology, we have to track two distinct systems. On one side, we have the anatomical pipelines, the physical structures like the uterus and fallopian tubes. On the other, the hormonal signals pulsing from the brain down to the ovaries. When a patient presents with pelvic symptoms, the diagnostic goal is determining whether the issue is a broken pipe, a structural blockage, or a crossed wire, a disruption in the hormonal signaling pathway. This framework is best tested by looking at secondary amenorrhea. Before diving into complex endocrine labs or imaging for rare structural anomalies, we have to establish a baseline. In a woman of reproductive age, missed menses is pregnancy until proven otherwise. A beta-HCG test is the non-negotiable first step in every algorithm. Bypassing this check means your diagnostic workup is built on a flawed premise, leading to clinical errors.
Primary amenorrhea is defined as a lack of menarche by age 15 with secondary sexual characteristics, or by age 13 without them. The workup follows a strict anatomical sequence. A common mistake is ordering a karyotype as the very first step. As the evidence shows, genetic analysis is only indicated after you've identified a specific structural or hormonal marker that warrants it. The path begins with an ultrasound asking, is the uterus present or absent? If absent, pubic hair acts as the signal. Its presence points to Müllerian agenesis. Its absence suggests androgen insensitivity. If the uterus is present, we check serum FSH. High means failure, low suggests delay. Anatomy dictates how we interpret the hormonal signaling. Without verifying the structures first, the endocrine data has no context. Acute pelvic pain requires differentiating between peritoneal irritation and vascular strangulation. This list includes life-threatening emergencies that require immediate intervention. Imagine a patient with sudden, severe pain, negative HCG, and a mass, but normal Doppler. The ovary has dual blood supply. A partial twist blocks veins while arteries still pump. Thus, normal ultrasound flow cannot rule out torsion. Severe clinical signs dictate emergent surgery. To sort through abnormal uterine bleeding, the Palm-Cohen matrix separates structural from non-structural causes. Physically, a symmetrically enlarged uterus suggests adenomyosis, while a nodular uterus suggests fibroids. Regardless of the matrix, postmenopausal bleeding is endometrial cancer until proven otherwise. A stripe thicker than 4 millimeters or age over 45 requires a biopsy. We also have to track the effectiveness of our treatments. While antibiotics are the standard for pelvic inflammatory disease, a failure to improve within 48 to 72 hours raises the suspicion for a tubo-ovarian abscess. Tracking clinical thresholds ensures insidious diseases like abscesses and cancer aren't missed after addressing initial symptoms. Let's apply these frameworks. Consider a 46-year-old with heavy bleeding and unilateral pain. First, run the HCG to rule out pregnancy. Next, because of her age, check the endometrial stripe thickness. Finally, remain suspicious of torsion regardless of what the imaging shows. For primary amenorrhea, anatomy comes before hormones. For adnexal pain, never trust a normal Doppler if clinical pain is severe. For abnormal bleeding, always biopsy if high-risk thresholds are crossed. Finally, if a pelvic infection isn't resolving, look for an abscess. These cues safely guide complex gynecologic presentations.